This is figure 1 of symphyseal diastasis, and here is a separation. And the text reads, rupture and separation of the pubic joint in response to extrinsic or intrinsic, such as birth, trauma. See yellow arrow, so you can see the space there. Figure 2 is an actual client. This is from the orthopedic research, and this is a birth trauma. Unusual to have that degree of separation related to birth, but it does happen in a very small percentage, and this was 47 millimeters here. You can see the separation here. And the text reads, the image on the left is postpartum day 1, anterior to posterior radiograph, which shows an unstable 4.7 centimeter symphyseal diastasis. This was reduced to 2.6 centimeters after wearing a pelvic binder for 4 days, and then it was reduced to 1.5 centimeters or 15 millimeters 6 months later, and you can see the callus formation. It's scar tissue becoming bone, okay, and much closer pubic bones there. And then this is from image 8, and this is a CAT scan image, and the pubic joint here is separated significantly, and through use of the pelvic binder there is minimal separation. That probably is normal. And up here is the SI joint, and you can see the black space where the joint has increased width, and from wearing the pelvic binder the joint space closes. So the text reads, CAT scan images show SI gapping in the upper left image and severe obstetric pubic symphyseal diastasis in the lower image, with significant reduction from pelvic binder applied at the trochanters. The right upper image shows reduction of the sacroiliac joints, and the right lower image shows reduction of the severe obstetric pubic symphyseal diastasis. It is noteworthy that only a small amount of pathological anterior sacroiliac joint widening in the amount of 2 to 6 millimeters occurs in the presence of an extreme separation of the pubic joints, anywhere from 10 to 47 millimeters, as is seen in images 3, 4, and 8. So it's very interesting to note that the separation that's visualized at the sacroiliac joint is small in comparison to the separation that's imaged at the pubic joint. This is another image showing the separation. This is, of course, a greater amount of separation in the sacroiliac joint. And earlier we did see image 8 that I'll throw up there one more time, again showing the significant separation at the pubic joint. So the SI joint widening is very slight in the presence of a significant widening in the transverse plane of the symphysis pubis. That was the main point. Obstetric pubic symphyseal diastasis is not well understood, and chronic patients do suffer, as reported by one author who stated, the persistence of symptoms in our patients emphasizes the need for careful examination and follow-up of these rare injuries. The outcome in our patients was poor, referencing diastasis, and results in the literature are equivocal. A novel theory is presented here which suggests that obstetric pubic symphyseal diastasis arthrokinematics, meaning that the movements in the joint, are distinctly different from that of a normal pregnancy and normal birth joint mechanics. The purpose of this poster is to bridge knowledge from the orthopedic trauma literature and propose a new biomechanical model based on unreported findings encountered by reviewing the images in the orthopedic trauma literature, and another purpose is to discuss novel treatment. Orthopedic manual physical therapists perhaps have much to offer the non-surgical population who suffer from pubic joint dysfunction, traumatic symphyseal diastasis, and obstetric pubic symphyseal diastasis. And of course, other clinicians have much to offer as well, such as women's health physical therapists, etc. This section is titled Evaluation, Stress Test Imaging for Occult Instability. Passively stressing the ilium manually in a posterior and lateral direction while taking comparison x-rays, meaning that there was a previous static x-ray for comparison, is a relevant, albeit underutilized, screen for acute occult surgical instability. This test has utility in the acute phase because there is considerable recoil that occurs very soon after traumatic symphyseal diastasis or after obstetric pubic symphyseal diastasis. Thus, the actual damage is at times occulted with traditional static imaging. The addition of stress testing to repeat X-ray has identified false negatives, which were elevated then to a diagnosis of surgical instability. One of the potential roles of manual physical therapists in the chronic pubic joint dysfunction, traumatic symphyseal diastasis, and obstetric pubic symphyseal diastic population is to perform stress tests while palpating the pubic joint width and also the verticality, and discern if there is any significant palpable widening or vertical shift that occurs. If moderate to severe instability is identified, then referral for stress imaging is of course indicated, and also referral to an orthopedic trauma specialist. Otherwise, focused rehabilitation should ensue. The next section is titled Birth and Symphyseal Diastasis Joint Mechanics. There are no contemporary imaging studies to validate specific pelvic joint mechanics of pregnancy, labor, and parturition. The traditional belief is based on X-ray studies prior to 1958, and they suggest that the pelvic outlet widens circumferentially, which is accomplished via sacral nutation, in which the top of the sacrum moves down and forward, and the sacral apex, or the bottom of the sacrum, goes back and up, allowing an increase in the anterior to posterior pelvic outlet dimension. And we're going to stop here, and we will continue as part 2.